Greet everyone. Normally, I greet everyone in a NACHWA webinar with scrolling through and giving shout outs, but we really want to reserve the bulk of our time today for a really important discussion. So NACHWA team, I'm going to jump right in if that is all set. So hi, everyone. My name is Denise Octavia Smith. I am a community health worker, and I bring you greetings from Hartford, Connecticut. In 2019, I became the inaugural executive director, and I just want to acknowledge the founding board members of the National Association, without which we would not be here. I also want to thank all of our members. I want to thank you for trusting us with your membership and for leaning into unity, which is at the heart of the purpose of the National Association of Community Health Workers. Our vision is to see CHWs across geography, ethnicity, gender, sector, language, and lived experience united so that we can support our communities to achieve health, equity, and social justice. So I want to welcome you all to the webinar today. We've got some incredible speakers as we discuss today the Medicare physician fee schedule. On July 13th, 2023, the Centers for Medicare and Medicaid, known as CMS, issued a proposed rule that announces and solicits public comment on proposed policy changes for Medicare payments under the physician fee schedule, or PFS. And you may hear a few acronyms today, but we'll try to deconstruct them, and other Medicare Part B issues. Effective on or after January 1st, 2024. With members and partners of the National Association of CHWs, we decided to pull together this environment to focus on a few clear objectives in the short time that we have with you today. Number one, we want to ask questions about the proposed rule change to authorize Medicare payment for CHW services. We want to try and describe questions and hear your questions and key areas of interest from CMS regarding CHWs. And we're also going to spend some time sharing with you so that you have a clear understanding of how to submit your own public comments online. I'm thrilled today to be joined by a few NACHWA staff members, but for brevity, let me just introduce two. I want to recognize Catherine Martinez, who has joined our team back in the spring and is now a full member leading our strategics initiatives as a manager. And I also want to acknowledge Angie Kuzma, who many of you know as our policy and advocacy manager. Again, I want to thank you all for joining. I'll put the objectives in the chat. And I would like for Angie Kuzma to come forward so that she can introduce our guests.
Hi, everybody. Good afternoon. As Denise mentioned, I'm Angie, she, her. I'm a community health worker in Portland, Oregon, and it's my pleasure to work for the National Association of Community Health Workers as the policy and advocacy manager. So we have incredible speakers with us today, Dr. Doug Jacobs and Georgia M. Simpson, and I will just introduce them and tell you a little bit more about them right now. Dr. Doug Jacobs is the Chief Transformation Officer in the Centers for Medicare and Medicaid Services, or CMS. Prior to this role, he most recently served as the Chief Medical Officer and Chief Innovation Officer for the Pennsylvania Department of Human Services, helping to oversee the state Medicaid and Human Services programs amidst the pandemic for the 16,000-person state agency. Under his leadership, the Department of Human Services created Pennsylvania's first equity incentive program in Medicaid, established new rules that incorporate community-based organizations to address the social determinants of health, and oversaw Medicaid's increasing movement toward value-based care. Dr. Jacobs is a practicing board-certified internal medicine physician and is an assistant professor of clinical medicine at the Penn State Hershey Medical Center. He's also an avid writer, having published pieces in the New England Journal of Medicine, Journal of the American Medical Association, New York Times, and Washington Post. In his current role at CMS, he's helping lead Medicare's efforts to promote value-based care, advance health equity, and encourage delivery system transformation. Georgia M. Simpson is a public health practitioner with 30 years of experience in advancing efforts to address racial and ethnic health inequities in the upstream social, structural, and environmental determinants that influence health and well-being. Ms. Simpson has worked at the local, state, and federal levels, applying her skills in the design and management of complex programs to meet population health needs. As the Regional Minority Health Analyst in the Office of the Assistant Secretary for Health, Region 1, New England, she promotes minority health priorities and coordinates efforts across the 6 New England states to advance equity goals. Georgia supports the New England CHW Coalition as well and co-chairs the HHS Interagency CHW Sustainability Work Group hosted by the HHS Office of Minority Health. So I'm going to turn it over to Georgia and Dr. Jacobs now. Georgia.
Thank you so much, Angie, and I hope everyone can hear me okay. Again, I'm Georgia Simpson. I'm in the Region 1 office. And today, if you can go to slide 1, please. There we go. This is just a tutorial, Public Comments 101. We want to share with you how to get to the proposed rule, give you an example of the content that you will see in the document once you're there, and then how to navigate on the document to locate the content that is of interest to you. Lastly, we will provide some screenshots of what to expect, what you will see as you go through the various areas where content is being asked for and how you enter that content in the comment form. Next slide, please. Well, actually, let's stop there for a moment because I do want to highlight, if you can go back, highlight a few very important things on the previous slide. The proposed rule that we are covering is CMS-1784-P. There we go. It's highlighted in yellow on your screen. It is very important to also note that this public comment closes on September 11th, 2023 at 5 p.m. And also important, this is a tutorial to provide you with guidance. Any questions should be directed to the agency and individuals listed in the proposed rule document. Thank you. Next slide, please. So very quickly, a snapshot of the tutorial, an introduction to some of its content. And 3 areas in particular will be on community health integration, principal illness navigation, social determinants of health, risk assessment. Those will be contained in the section known as the health-related social needs, and you'll see more on that in a little bit. Provide you with user-friendly instructions on how to get to and then complete your public comment, and then provide you with a list of additional resources, 2 of which are at the bottom of this slide, which include the press release, as well as the fact sheet on the calendar year 2024 physician fee schedule proposed rule. Next slide, please. And I will now turn it over to my colleague, Dr. Jacobs.
Thank you so much, Georgia. First of all, it's just wonderful to see all of your faces today. Great to see amazing turnout, and excited to go over some of what was in the proposed rule that's particularly germane to this conversation. So the proposed rule has these 3 services established as codes. And what a code means is basically when a provider is identifying a certain service, they identify the code for payment when they submit it to Medicare. And so there's 3 codes that we wanted to draw your attention to in particular. This is in the section related to health-related social needs. And so the first is community health integration. The second code is called principal illness navigation. And the third code is a social determinants of health risk assessment. So I wanted to take a brief moment I think the one that's probably most pertinent for this conversation is the service called Community Health Integration, or abbreviated CHI. So you might see that every so often when you're looking through the rule as well. So community health integration, the idea behind it is it really allows for the services typically furnished or performed by community health workers and puts it into this code to try and describe a lot of it, or as much as a lot of the aspects, maybe not all of the aspects that everyone on this call does every day, but part of that is for the comment period as well. So the community health integration code describes initially a person-centered assessment where the community health worker or other auxiliary personnel, and we use this term auxiliary personnel because just taking a step back, we use the term auxiliary personnel to essentially mean individuals who can't bill Medicare directly. So community health workers are in the category of auxiliary personnel. So if you see that in the proposed rule, auxiliary personnel can perform services under the general supervision of a provider that can bill Medicare directly. So when I say auxiliary personnel, that's what I'm referring to. So we describe this code and say that auxiliary personnel, including community health workers, can perform these services, which involve the person-centered assessment. So that's getting the patient's life story, their goals, needs, and preferences, including cultural and linguistic needs. That also includes administering social determinants of health assessment to understand unmet social needs. It's also care coordination between the providers, between inpatient, outpatient providers, and really navigating the healthcare system as a whole. It's also contextualizing health information provided by the patient's treatment team, armed with the information about the patient and their life story, helping to better contextualize health education that's delivered. Also building patient self-advocacy skills to participate in medical decision-making, mentioned health system navigation, and also facilitating the behavioral health change, or the behavioral change that's needed to meet those treatment goals. It includes providing social and emotional support. It also includes facilitating access to community-based social services to address unmet social needs. And it also includes leveraging the lived experience that auxiliary personnel, including community health workers, can bring to the care team and for the treatment of the patient. So I would encourage you to read the rule directly to get a full understanding of all of these different service elements. There's more than what I just mentioned now today as well. So the way that this would work is that the auxiliary personnel, including community health workers, would be able to see the patient and you'd have to see the patient for 60 minutes in a month. And then you could bill the initial code. If the treatment team sees the patient for more than 60 minutes in a month, then you can add on another 30 minutes and every 30 minutes. And also we have proposed in this rule, because we know that a lot of community health workers are employed by community-based organizations, that community health workers could continue to be employed by community-based organizations. And so long as the community health worker is under the general supervision of a billing provider, then that would be okay. And that term general supervision, it's a little bit of a term of art. Essentially what it means is that the provider, the billing practitioner, whether that's a physician or nurse practitioner, certified nurse specialist, they don't have to be physically on site with the community health worker when the services are being performed, just as long as there's general oversight over the activities. And so with that, there's the last piece that I wanted to highlight is that we also propose that there's certification or training in order to perform these services. So a lot of states, I think as folks know, have state certification programs for community health workers. In the event that the state does not have those kinds of certification requirements, we articulate certain categories that there need to be some kind of training in. And I'd refer you to the rule to take a look at that training as well. We developed it from the C3, the core competencies for community health workers, which I suspect a lot of you might have had a hand in participating. So I think with that is the community health integration code. Oh, sorry, one more piece that I wanted to highlight there. The community health integration code, it starts out with a basically what's called that E&M visit, or evaluation and management visit. This is kind of the typical visit that like an outpatient primary care provider or other types of provider will have with the patient. This is referred to as the initiating visit when you read the rule. So essentially after that, and it's for patients specifically that have a social determinant of health need that affects the diagnosis and treatment of a medical problem. So that could be, for example, the patient has food insecurity and they also have diabetes. There's infinite probably numbers of examples and permutations of that, but that's another aspect I wanted to highlight. Okay, I know that was a lot. All the details are in this. It's a 2,000-page rule, but this section, I promise, is a lot smaller, and we're going to go over how to comment on the rule. The main difference with this principal illness navigation code is it's specifically for patients with a high-risk condition. And so it doesn't need to, you don't need to have a social determinant of health need that's affecting the diagnosis and treatment of the medical problem. But so long as the patient has a high-risk condition. And the other change and difference with principal illness navigation is that we specify that the person performing the services should have specialized training in whatever that high-risk condition is. So it might be relevant for community health workers, depending if you have special training in a certain type of disease or condition, or we're used to working with certain types of patients. So that's the main difference between community health integration and principal illness navigation. And lastly, the social determinant health risk assessment code, it kind of is exactly what it sounds like. It's paying providers in their treatment team to assess patients and the risk for social needs that might affect the diagnosis and treatment of medical problems. So that could include food, housing, transportation, other social needs like that. So I know that was a lot, but I think we can move on now from this slide. And I just specifically wanted to highlight as well, while you can, any of you are welcome to comment on any part of these proposals. Every time we come out with a rule, though, we also have what we call requests for information, where we specifically highlight areas that we're asking questions. And so the following slides are just going to describe those areas. Next slide. So in the community health integration section, we ask whether it would be appropriate to specify the number of hours of required training, as well as the training content and who should provide the training. We also asked like how these services would typically be provided. So in person, audio, video, two-way audio, whether CMS should require patient consent for community health integration services, whether states typically cover services similar to community health integration under Medicaid programs, and whether such coverage would be duplicative, and whether there are other service elements not included in the services that I mentioned, and when you read the rule, that are important to addressing unmet social needs and affect the diagnosis and treatment of medical problems that CMS should consider for coding and payment in the future. Next slide. And on the principal illness navigation section, they're very similar questions here, so I'm not going to read through them all, but just to note that it's available here as well. Next slide. And finally, for the social determinants of health risk assessment section, whether CMS should require as a condition of payment that the billing practitioner also have the capacity to furnish community health integration, principal illness navigation, or other care management services, or have partnerships with community-based organizations to address social needs. Reason being is if you're screening for something, it would be good to have some kind of follow-up and ability to do something afterwards. And so we're asking a question about that. And then also comments on where and how these services would be typically provided, along with other any other aspects of the proposed social determinants of health risk assessment service. So I think with that, I'm going to turn it back over to Georgia.
Thank you so much, Dr. Jacobs. Okay, so I'm glad he's the one who shared with you that it's a 2,000-page document. And so you may be asking yourself, how can I navigate such a large document? And so the tips that I will share with you are ways in which you can anchor keywords, phrases, abbreviations through a search that will take you to where your words are located in the document. So this is an example. In your browser, you'll see when you start using the system, you'll have a browser, and you'll have, in this case, this is the regulations.gov. We'll get to that in a moment, and the document number, the specific document number. It's not necessarily readily apparent how to do a find in the document. The entire document will download. And so there are 3 buttons to the right-hand side of your toolbar. When you click those 3 buttons, they're all together, it will give you an option through a drop-down menu to do find. When you select find, it will populate a search bar. And that's where you can then enter a keyword, phrase, in this case, an abbreviation, CHW, in the empty bar space. And it will honestly tell you how many times that appears in the document. In this case, CHW appears in the entire document, approximately 28 times. And you'll see it also highlighted throughout the document where it's located. So the instruction here is, again, your browser, go to the 3 dots, select find, your window will appear, you enter your keywords, and then your search results will show up in the document. Next slide, please. So what we have here are some keywords that may be helpful to you. In the health-related social needs section, it's actually identified as section 27, services addressing. If you type that in that keyword search, it will anchor you in the document where that discussion begins. And as we've shared on previous slides, within that section, you will find the community health integration, the social determinants of health, as well as the principal illness navigation narratives. It's really important to be able to go through the entire section for not just what Dr. Jacobs shared in terms of information requested, but also to understand the context. So you anchor yourself using your keyword search in the particular areas of interest. Other keywords that have been identified here are, if you literally type B.community, it will take you to community health integration. And as the other examples also highlighted demonstrate, D, social determinants of health shows up. Additional keywords can be, or terms can be, community health worker, care navigator or navigator, peer support or peer support specialist or peer specialist, also CHW, which is not case sensitive, whether it's all uppercase or lowercase, how you type it, it will appear. But CHI, for community health integration, for example, is case sensitive. Why? Because CHI appears in many words, those 3 letters combined. So for the purposes of navigating this document, and if you're looking for the CHI or community health integration section, it is case sensitive, as is PIN, P-I-N. Next slide, please. All right, so submitting your comment, let's get started. Next slide. So how do I submit a comment on regulations.gov? So clearly that is highlighted, regulations.gov, and that will be one of your starting points. What we'll provide here is an overview with screenshots to follow. So the comment button can be found on the following pages that have been identified for you on this slide. So that includes docket details page, when a document within the docket is open for comment, document details page when the document is open for comment, and document search tab with all search results open for comment displaying a comment button. When you click comment on any of the above pages, it will display a comment form. And you can enter your comment on that form as well as attach files. Please note there are the number of files has a maximum limit of 20, and each file can be up to 10 megabytes. Next, choose whether to identify yourself as an individual, an organization, or anonymously. Be sure to complete all the required fields depending on which identity you have chosen. And please note that information entered on the web form may be viewable publicly. Once you've completed all the fields and chosen your identity, the submit comment button is enabled. So up until that point, it's not enabled. Upon completion, you'll receive a tracking number, and you'll see how to opt for receiving your tracking number by email. Some agencies also accept comments by mail, fax, or email. You will find in the address section how to do that if it's available for a particular proposed rule open for public comments. Next slide, please. All right, so these are the screenshots. Go to www.regulations.gov. What will come up is a screen looking similar to this one with a search bar. The easiest way to do this is in the search bar for this particular proposed rule document is to type in CMS-1784-P. And it's not case sensitive, but I've entered it that way. Next slide, and then hit search, of course. Next slide. What this will appear once you've done that, I think it's important to note that the blue highlighted title will be clickable when you land there. When you click on that, the entire document, or actually the next screen will appear. So that's one way to get to where you will begin looking at your document. Or you can use the link below. Both this clickable blue title and this link found at the bottom of this slide will both take you to, when we get there, the next screen. I want to highlight here though, please pay attention to the comments due September 11th, 2023. That is one way you will know you have landed on the right document in the right place. Next slide, please. This slide, this screen shows you what you will land on once you've clicked one of those two areas, either the blue title or the link. And there are two functions on this particular screen. One, and I'll start over on my right-hand side, is download. The document might automatically download and all the text will appear on your screen. There may be a 2 to 5 second delay, but it may auto-populate. If it doesn't, of course, you can click download and it will then appear. And then the instruction provided here is refer back to slides 8 and 9 on how to do the keyword search once the document has downloaded. The other function is comment. When you hit comment, that will take you off of this screen to the comment form. So next slide, please. And this is where you will begin to write or enter your comments, attach files. It is really important to start at the top, where it actually has a clickable commenters checklist. That is another one-page document that provides you with tips for providing effective comments, as well as detailed recommendations. It is really important to click on that checklist, review it, and know what it's providing you with. Next is the comment. And this is where you honestly start writing your comments. You will see throughout the this section that is accepting the comments part that they want you to refer to file code CMS-1784-P. It is identified where to appropriately make that notation. So that's one of the things that the commenter's checklist will show you. After the comment and start typing comment here line, there is a section called comment category, and it's a drop down. And what it's simply asking you to identify is, or answer the question is, what is your comment about? So there are several options in that drop down. You select the one that's most appropriate. And then finally, what I'd like to show here on this is the attached files. And this is what I mentioned on the previous slide, where you can attach up to 20 files. Each file cannot exceed 10 megabytes. Next slide, please. Enter your email address and other demographic information. It's very clear where your email address goes. This little box called opt to receive, that's a checkbox that you will select if you want to get an email confirmation of submission and tracking number. Thank you for the expansion of that. Again, it's important to check that, to opt to receive email confirmation of submission and tracking number. And then again, tell us about yourself. And this is where you share whether you're an individual submitting. So if you or another single person is the author, you can select an organization. So that's if you are a company, an organization, or government agency. And then there's anonymous, if you do not want an entity associated with the comment. Next slide, please. And this is the last slide on about this particular topic on the comments page, or comments form, I should say. Select I'm not a robot. And I can't stress that enough, because I am that person who will sometimes forget to select that. And you can't go any further if you do not identify yourself as not being a robot. So please remember to select I'm not a robot. The other thing that's really important is to understand your privacy notices and your rights within that. Those are identified both above the submit comment option and just below it, where it's been highlighted or circled in red for you. And then the last step, once you've done everything else and you're good to go, you select or click submit comment, and it's found in the middle of the page. Next slide, please. Congratulations, you did it. Next slide. Helpful resources, some were put throughout the slide presentation, but all of these are very helpful to you. The last one on this list, where it says regulations.gov, you are free to go to regulations.gov and look at any rule or document that's open for public comment. You can also see those that have been commented on in the past. That's a resource for you, or if you're interested. The other thing, again, I just want to simply note, I shouldn't say simply, it's an important notation, that you can review and comment on any part of the proposed rule. Next slide, please. And here are the addresses and notations that to be assured of consideration, that means to have your comment considered, you must, or it must be received at one of the addresses below no later than 5 p.m. on September 11th, 2023. It also notes to include file code, as we've said several times, CMS-1784-P. These are the three options available to you, the three ways that you can submit: electronically through regulations.gov. Those were the screenshots that have been shared. You can use regular mail. There is a specific address, and it says follow address only for that option. So be certain to pay particular attention to the address that you are using. And you must allow sufficient time for mailed comments to be received before the close of the comment period. And then there's the express or overnight mail option. Again, please follow the instructions related to that, as well as its specific address. Next slide, please. Thank you. That's it.
Thank you so much, Georgia and Dr. Jacobs. It's just really great to have you here. This tutorial is incredibly helpful. And what a rare treat to have you here with us and your expertise. I'm gonna try to transition us into a Q&A, and I will pause for now and just ask if there's anything, Dr. Jacobs, you wanted to add at this point, or
maybe I'll just say that in general, just so folks know, part of coming out with a proposed rule when we're in this period, which we're in now, called the comment period, I'm generally limited to what I can say to what's in the proposed rule. So if folks ask questions that I can't answer, don't be offended. I'm just going to say I can't answer it, but it doesn't mean I don't want to answer it. It's just I'm bound by what I can and can't say. So but I'll probably, in those circumstances, encourage everybody to comment and ask us those questions in their comments as well.
that makes sense.
Yeah.
Thank you. So we're going to ask folks to type your questions in the chat. We do have upwards of 300 people here, so we're not able to do a come off mute situation. So I'll just give folks a moment, and maybe if Catherine, if there's a slide we could put up, maybe it was like number 3, where it kind of gives the overview of those 3 areas, or something that folks can take a look at about, areas they may have questions about.
Sure, 1 second.
Thanks. And in the meantime, Dr. Jacobs, are there certain areas of interest that CMS still is looking for comment on? You want to highlight?
So I'll say maybe just that the areas that we talked about, where when you're reading, it says CMS requests comment on, and then there's something afterwards. Those are areas where we're specifically highlighting for where we want to receive information. So I'll draw your attention there, but in general, when you're reading the reg, if there's anything that you feel is important, we want to hear from you. So don't limit yourself to just answering those questions.
Great, thank you for clarifying. All right, so yeah, this is a rare opportunity to hear from these experts. And so we welcome your questions in the chat. If there's anything you've heard today or seen that you want maybe some clarification on, or feels particularly important to you, I'd love to hear from you. Okay, so I'm seeing a question from Megan. Please clarify what general supervision from a billing provider should look like for a community-based organization.
Yeah, I can take that one. So when we say general supervision, we mean the main area to distinguish it from is what we call direct supervision. So direct supervision is the physician, nurse practitioner, certified nurse specialist, someone who can bill Medicare directly, has to be on site directly supervising. That is not what we said in the community health integration service. We said general supervision. So what that means is whoever's billing us, the physician, the nurse practitioner, the certified nurse specialist, they don't have to be physically on site. It's just under their general oversight. So that might mean in different sorts of situations, like general check-ins, like the work that's being done, the billing practitioner is aware of, but they don't need to be physically there. So that opens up some flexibility in terms of how these services can be provided.
you so much. There's questions kind of coming in hot, so I'm trying to keep up here. Can we submit a comment, both individual and a separate comment via an organization?
Georgia, do you know the answer to that one?
That's a great question. I don't have the answer to that one. I'm trying to reflect on the commenters' tips that I mentioned, and I don't recall an answer for that, but I'm certain that when you go to the document and you look at the list of, there are contact people within the actual document that you could probably direct that comment or that question to. My apologies.
Thank you so much. After September 11th, how long is the time period that all comments are reviewed to when the proposed rule is considered and the time frame for consideration?
Great question. So with the physician fee schedule, every year we come out with the final rule before or on November 1st. So we always hope to get it out earlier. It doesn't always work out that way. But we, in between when the comment period ends, so September 11th, and when we come out with the final rule, we have to review all the comments, and we really do read all the comments as well. So some long reading sessions on our part.
Gonna say, how do you do it? That's cool. Thanks for clarifying. Got other questions here coming in. Thanks for your patience, everyone, as I try to read these. What if a community-based organization does not provide medical services, but they do navigation and case management? How do CHWs get paid or participate?
Yeah, so that's a great question. What we proposed in the rule was that we recognize that a lot of community health workers are employed by community-based organizations. And so the community-based organization itself doesn't need to provide other medical services or clinical services. The community-based organization can provide the community health workers to be supervised by the billing practitioner in the clinical setting. So that means that the billing practitioner, who is clinical, physician, nurse practitioner, clinical nurse specialist, while they're offering the general supervision, the individual providing the services, auxiliary personnel, including community health workers, don't need to provide clinical services. The community-based organization that they are employed with, there's no requirement in the proposed rule that they provide clinical services as well.
That sounds like great news. This is an issue we talk about a lot in the field, so very exciting. Thanks for your patience, everyone. I'm just trying to read quickly. Some of it's moving around very fast, so. Okay, will hospitals and provider-based billing be eligible to bill? We often run into not being able to bill due to not being a federally qualified health center and bring provider-based billing. I'm not sure if I'm understanding the question, but maybe that makes more sense to you, Dr. Jacobs. We can move on if not.
I'm also a little bit confused with what the question's asking. Sorry.
That's okay. If the person who raised that wants to, if you could rephrase that, we'll try to come back to it. Okay. How would the CBO be connected to a supervising clinician?
Yeah, so we're basically saying, as we proposed it, I don't think we got into the details of what the contracts would look like. That would have to be talked about between the community-based organization and whatever the provider entity is. So that might be an FQHC, a rural health clinic, outpatient physician's office, and what exactly the contract looks like between the community-based organization and the physician, our rule was silent on. So I don't know if that helps. There's flexibility. Sure.
Okay, thank you. This feels like just a good time as maybe NACHWA staff to raise one of our recommendations that we've made before about requesting that CMS issue some really clear guidance about these types of relationships so that there's we can minimize the barriers to participation among CBOs and other organizations that employ CHWs. So I appreciate that it sounds like we're headed in a direction of exploring this area more deeply with the request for information. That was just a statement, not a question for me. Let's see. Would the billing be a PPS rate at an FQHC or a different rate? Sorry, I'm not sure what the PPS rate means.
So I think FQHCs are paid in this prospective rate, which I think that's what the question is addressing. The way that we talk about the payment for this code, it would be on a monthly basis. And there we identify a certain payment for 60 minutes and a certain payment for the 30-minute add-on, if there's an additional 30 minutes each month. And so if 60 minutes are billed in a month, it would be one payment. If 90 minutes are billed in that month, it would be another payment. And then and because it's a monthly code that can be billed, it could then be billed the next month. So that's how it would be billed. When it comes to FQHCs, because we recognize that a lot of these services would probably potentially be provided by FQHCs and RHCs who have a history of working in the community. We also proposed that outside of the PPS rate, there would be this code would be added on to the existing care management type codes that that FQHCs could bill for.
Thank you.
I will say, if you want more details on that, I would read the FQHC section of the rule because we talk about it there as well.
Okay. Care coordination that might require creating an inventory of resources and establishing agreements with other organizations and CBOs. Can the time used to complete these tasks be billed?
So we include care coordination as a general category that can count towards the time. I think for maybe more specific questions than that, I would just recommend asking CMS the question or providing the comment and as a comment as well, if there's something else that needs to be clarified.
Great, thank you. And I want to just do a quick time check here and make sure we are not wearing out all of our time. Let's see. Okay, I think we have a time for another 5 minutes or so. Does that sound okay? Of questions, that is, before we wrap up.
If you're asking me, yes, that'd be
Okay.
great.
All right. There was one about, okay, is treatment adherence included in any of the categories that you talked about?
So we don't, I'm trying to remember. I can't remember offhand if we mentioned treatment adherence specifically within any of the categories. We imply several times that the services are intended to help the patient comply with the treatment plan in general. So I think I would definitely take a look at the service categories, but my inclination is probably yes. But again, that's something that maybe just asking CMS in a comment if there's something else that you feel like needs to be additionally clarified would be great.
And so will this rule change set payment rates, or will that vary by state?
So because it's a Medicare rule, it sets payment rates for Medicare. And so, for example, a state Medicaid program is still free to set its own individual payment rates. One thing to maybe highlight is that when we create a new code for something, a state Medicaid program could decide that they want to use that code as well. And they can come up with their own payment associated with it. Commercial insurers can decide to use that code. So it can have implications beyond just Medicare, but the payment that I was talking about today is Medicare payment.
Right.
Angie, we have a few more questions.
Yeah, please just chime in if I've missed any that we really, we need to hear from. Thank you.
Sure. So Dr. Jacobs, here's another question. What if the CHW works at a different organization than the billing provider, but the provider still provides oversight? For example, if a CHW works at a homeless shelter and there is a nurse practitioner who visits from a nearby clinic and provides oversight, but is not employed by the same organization.
That's a great question. When we talk about in the proposed rule, this idea that community-based organizations can employ the community health worker and then they can receive oversight from a different provider group or just the billing practitioner, it essentially incorporates that idea. I think if there's maybe some more specific clinical scenarios of interactions between community-based organization like a homeless shelter and a billing practitioner, certainly that would be fair game to like ask us questions about if it's not clear. But we did try to talk about that in the proposal as well.
Thank you. So I have another question. If CHWs are hired by federally qualified health centers, is that considered, quote, tied to public funding, unquote, and therefore considered as lobbying?
That's not something I'm aware of. I think if there's something that is not clear that maybe needs to be clear more, something that CMS doesn't have oversight over is, of course, like the grants that various entities get, because we generally pay for services in the healthcare setting. So I think if there are certain questions there that that folks want to ask, I think that would certainly be helpful for us to hear from.
Okay, I have a few more questions coming through. My organization gets care plans signed by medical providers before we begin seeing clients. Let's see. Would that count as enough supervision from a billing provider?
So I'm not going to be able to answer that. I would just refer the person who's asking the question to where we define general supervision in regulation. And so it's basically the definition of general supervision. And it's also under this like larger category called incident to billing. And so if you want to take a look at that and think about the individual situation, that would probably be the best course of action.
Thank you so much. Let me hand it back to Angie.
Is there any guidance on the proposed rule that addresses any requirement around CHW documentation for billing purposes?
So, great question. We have in the proposal a part where we talk about, remember before I said that the patient needs to have an unmet social need that affects the diagnosis or treatment of their medical problem. We say that the patient needs to have in their chart somewhere an identified social need. And so there are certain codes called diagnosis codes. And some of you may have heard of this term called, it's a little bit wonky, but it's called a Z code. It refers to basically codes that are social determinant of health needs. So we say in the proposed rule that the patient can have a Z code documented as a way to identify the social need. Alternatively, the patient can also just have the social need documented in the chart and how it affects the diagnosis or treatment of their medical problem. And that's done in conjunction with the billing practitioner. So the billing practitioner in their first visit with the patient might, remember I said that, talked about that initiating visit. That can be in relation to the initiating visit before the monthly billing starts.
Great, thank you. So we've come to the end of the 5 minutes that I had flagged earlier. So we're gonna bring us to a close and say thank you. We have actually Lucas from Partners in Health US with a quick announcement for us. And we can just unmute Lucas if he's here. Oh yeah, I see Lucas.
Hi, Angie. Can you hear me? Thank you so much to Nachwa for organizing this awesome call, and to Dr. Jacobs. I just wanted to share, we're organizing some office hours where anyone with any questions can drop in. Definitely not promising that we'll have all the answers, but just creating a space to try and help with any questions around how this rule impacts CHWs, or on some of the comment instruction pieces that Georgia described so well. So just offering, definitely happy to help alongside Nachwa, but thank you so much.
Thank you, Lucas. And we put the link for that in the chat here. I'm gonna hand it back to Denise to close us out.
Okay, hey, good afternoon, everyone. I just want to thank you all for striving with the chat. I was not aware that you couldn't see one another's questions. That's my oversight, but I do believe we were able to get most of them lifted up. So yes, we'll have the recording sent out. So for everyone who registered, please look for that. And we're just waiting on confirmations for the slides, but of course they're presented in the recording. So at minimum, you'll have that. I'll ask one of the team members to also put into the chat the shortened versions of the documents that really zero in on these focus areas for CHWs that we talked about. No problem, Megan. I'm glad that we were able to host this. Let me thank Dr. Doug Jacobs and Georgia Simpson from CMS and OMH respectively. I really do appreciate their partnership. Listen, we did this because there was a call and there is great interest for CMS to hear the voices of community health workers, of promotores, of our community health representatives, of our aunties, of peers, obviously, and many allies in this community and on this call today. Without our advocacy, without our presence, taking time out from our day to lean in to these opportunities and to provide comment to the extent that we can, either as individuals or collectively within our organizations. This allows us to pursue sustainability that is equitable, that respects the profession, that protects the profession, and that advances authentic partnership. So we are grateful for all the presenters. Let me thank Catherine Martinez, Marlene Rivera, working in the background, and Angie Kuzma. Thanks to Lucas Allen and all the folks from PIH. Special shout out to Carl Rush, who also was working in the background to make sure that we could bring this to you. And to everyone, please, look out for that email. Take an opportunity to participate in the office hours and look closely and listen closely again to the recording so that you can lean into all of those instructions and make sure that your comment is submitted no later than September 11th by 5 p.m. Thanks everyone for a great webinar and take care.
Thank you all.
Thank you, everyone.